This slide's presentation will cover the pathophysiology and management of amyotrophic lateral sclerosis, which is also known as Lou Gehrig's disease. This slide has some statistics that you need to be aware of for patients with ALS. First, the demographics. The onset is typically between the ages of 50 to 70 years of age, and males are affected 1.5 times more than females. This is a really sad disease because once you're diagnosed, there is no cure. Death is usually 3 to 5 years after you start noticing your symptoms, and it's usually by respiratory failure. Luckily, it's not very common. The incidence is only 1 to 2 per 100,000 people, but it is the most common motor neuron disease in the United States. I've highlighted the word motor here because it does not affect sensory function. It specifically targets alpha motor neurons and upper motor neurons in the motor cortex. Approximately 10% of individuals have a genetic component that predisposes them to ALS. The others are unknown. 90% of individuals with ALS do not have a family history. There are some possible risk factors associated with developing ALS, and those are being a military veteran, having neurotoxin exposure, or some sort of trauma. This slide shows the pathophysiology of ALS. As I mentioned previously, it's a motor neuron disease, and it involves the generation of both lower motor neurons, including the motor cranial nerve nuclei in the brainstem. Interestingly enough, cranial nerves 3, 4, and 6, or those involved in ocular motor function, are spared. Patients have difficulty with cranial nerves 5, 7, 9, 10, and 12. Other lower motor neurons are the alpha motor neurons in the spinal cord. If you look to the right-hand side of the slide, you can see the ventral gray horn with the lower motor neurons, or the alpha motor neurons. Those are the standard motor neurons that innervate all your skeletal muscles. In this patient presentation, upper motor neurons are also affected, and these are the motor neurons found in the primary motor cortex. As you can see in the picture on the right-hand side of the slide, the upper motor neurons exist in the primary motor cortex. However, they send out axons that are both the corticospinal and the corticobulbar tracts. Okay, when the upper motor neuron cell bodies die, that leads to scarring or sclerosis in the corticospinal and corticobulbar tracts. The corticobulbar tract is going to be affected in the brainstem, and the corticospinal tract can be affected throughout the brainstem as well as the spinal cord. Okay, clinical presentation here. We'll just go with the name. Amyotrophic to start out with, and amyotrophic is going to be lower motor neuron. That's the alpha motor neuron degeneration. If you remember, lower motor neurons present with paresis or paralysis or muscle weakness, muscle atrophy, fasciculations. Muscle is going to present with hypotonia. The patient is going to be hypo and or areflexic, and they can also have respiratory problems. And there's also cranial nerve degeneration. Patient is going to present with difficulty chewing, dysphagia, and dysarthria. And these are all due to alpha motor neuron degeneration, as well as cranial nerve degeneration, which are lower motor neurons. The other part of the clinical presentation is known as lateral sclerosis. And lateral sclerosis represents the upper motor neuron problems. And here the cortex motor neurons are degenerating, as well as the corticospinal and corticobulbar tracts. This leads to a loss of dexterity, muscle paresis, spasticity, upper motor neuron, positive Hoffman's and Babinski, as well as hyperreflexia and spastic dysarthria. So that spastic presentation is going to be indicative of the upper motor neuron problems. Okay, another clinical presentation that you should be aware of is that the majority of the onset is known as limb onset, and this accounts for 70 to 80% of the patient population. As opposed to the Guillain-Barré presentation, which was symmetrical, ALS presentation is asymmetrical, and it starts with distal extremity muscle weakness, whether it's upper extremity or lower extremity. Patient's going to report of difficulty with stumbling. They might feel clumsy with their hands, having difficulty buttoning their smaller shirt buttons, or they might have difficulty holding on to items. The other possible onset is known as bulbar onset, and this is 20 to 30% of this patient population will start out with the bulbar onset. And this is where brainstem nuclei are affected. And as I mentioned previously, you're going to see cranial nerve affected with tongue fasciculations. Patient's going to have difficulty with chewing, think cranial nerve 5, and swallowing and speaking. Okay, there's also ALS plus syndromes, and this is typically associated with the familial or the inherited ALS. The ALS plus syndromes are all the ALS symptoms plus cognitive impairment. Okay, another piece of the clinical presentation is oftentimes these patients aren't diagnosed right away. When their alpha motor neurons die, their weak muscles are working harder to perform the same activity, and that's going to have the person feel fatigued easily. Okay, when the motor neurons die, if you look down at the picture on the bottom portion of the slide, the healthy neuron attached to the muscle, or that motor unit, is intact. If you move to labeled B, the motor neuron dies, so there's deinnervation of that motor unit. And then what happens is the adjacent motor neurons actually start to sprout their axons and start to reinnervate that muscle. This actually helps preserve the strength and patient function early on, but as I said, it results in patient fatigue. But what happens is over time, if the motor unit loss is greater than 50% the rate of reinnervation, then the patient can't compensate for the degeneration of the neurons, and they're going to present with even more fatigue and more strength loss. To be diagnosed with ALS, patient has to present with weakness or atrophy. So weakness can be upper motor neuron or lower motor neuron symptoms. Atrophy, think lower motor neuron. Hyperreflexia and spasticity, hopefully at this point you're thinking upper motor neuron. Okay, and all these symptoms have to progress over time. If you move to the far right-hand side of that diagram, you can see it for a definite diagnosis of ALS, you need 3 regions that have either lower motor neuron or upper motor neuron signs. Another way you can definitely be diagnosed with ALS is if you move to the second column from the left-hand side. If you have one region that has both lower motor neuron and upper motor neuron signs, it's considered possible ALS. But then if they do some genetic testing and identify the gene that they know is responsible for ALS, then you definitely have familial form of ALS. Different variants of ALS that you need to be aware of, and the kinds of signs and symptoms that they present with. Okay, they're also going to have different progressions over time, and we'll talk about that a little bit more at the end of this slide's presentation. So, first type, ALS, you're going to have upper motor neuron, brainstem and spinal region, and lower motor neuron, both brainstem and spinal region symptoms. Then the second is PLS, or primary lateral sclerosis. Here you're going to be limited to mostly brainstem and spinal regions. Those are going to be your upper motor neuron signs and symptoms, but there's no lower motor neuron signs and symptoms. Then you have progressive spinal muscular atrophy, or PMI. There's no upper motor neuron signs and symptoms, but you have spinal region motor neuron signs and symptoms. And then you have your progressive bulbar palsy. No upper motor neuron signs and symptoms, but they have brainstem region lower motor neuron symptoms. So these are the people that are going to present with the lower motor neuron tongue fasciculations, dysarthria, and dysphagia early on. And then finally, you have the pseudobulbar palsy, where the upper motor neuron regions of the brainstem are affected, but they have no lower motor neuron signs and symptoms. Of all of these presentations, the worst prognosis is to have any kind of bulbar involvement early on. This patient population definitely involves a multidisciplinary approach. This slide shows the family. The patient is in the middle, and the family and or caregivers are very close to the patient. But in addition to those, we're needed nurses, OT, PT, speech, language pathologist, nutritionist, since that person is going to have trouble swallowing. There may be decisions that the patient might prefer to have a PEG tube. Research has shown that helps with survival just a little bit. Pharmacist for any medications, definitely pulmonology specialist or respiratory therapist, because this person they're ultimately going to die of respiratory failure. A lot of decisions, and the decisions really should be made early on whether or not they want to get a tracheostomy and be on ventilator support at the end of their life. Definitely psychologists and psychiatrists, because that person is going to have a lot to deal with psychologically. Okay, they're going to undergo depression and anxiety and loss of self. They're going to lose all of their muscle function over time, and they have to deal with the consequences of this devastating illness. So definitely a multidisciplinary approach. And you should know that there are special ALS clinics set up all across the country that offer patients diagnosed with ALS all of this support at one time in one place. Medical management. So as I said, there is no cure for ALS. Once you get it, death is imminent. And depending on how you're treated and the options that you choose, for example, PEG tubes or ventilator management, you're going to die within 20 years. One thing that they have used previously as far as medical management is the drug riluzole. And this is a disease-modifying agent, but the use of this drug only extends survival by 2 to 3 months. So the other problems that patients have because they have difficulty with facial nerve paralysis is the sialorrhea, where they're going to be drooling because they can't control their facial muscles. And to manage this, it's typically an anticholinergic drug. As I said, respiratory impairment is going to be huge. The patient may choose to use non-invasive positive pressure ventilation, which is shown in the picture on the right. See, it's not an endotracheal or it's not a tracheostomy. It's just a face mask, a helmet, or some other nasal mask. And this is recommended when the FVC is less than 50% of normal. Alternatively, the patient might choose a simple BiPAP machine. Okay, to manage spasticity, baclofen is usually the drug of choice. Analgesics, NSAIDs, and narcotics to manage pain. And if the person has any kind of bulbar palsy, they may present with pseudobulbar affect. Okay, dextromethorphan is the drug of choice for treating that. And to help with patient fatigue over time, Provigil. I'm just giving you an idea of the kind of medical management that's available for these patients. The actual drugs themselves, you don't really have to worry about knowing their names, but just realize that there's a host of symptoms in this patient population that have to be managed. Okay, PT examination. You definitely want a good history. You want to know when the symptoms started, how they started. Standard presentation is distal extremity on one side, maybe upper extremity, and then maybe later on distal extremity on the other side, or possibly a lower extremity on the same side distally. Knowing that the patient has a spinal origin versus the bulbar origin, where they might have trouble with tongue fasciculation, swallowing and chewing, that sort of thing is going to be important. Managing the patient's pain. How much pain are they in? What's causing their pain? Fatigue. Is the person dealing with serious fatigue at this time? Definitely want to take their vitals, make sure that their O2 sats are good. You want to do an intake screen, check out their posture, do standard gross range of motion and motor screens, check their cognition because they might be an ALS plus variant, and you need to know if they're cognitively intact. You want to check for sensation. Typically in this patient population, you wouldn't expect any sensory deficits, but it's always a good idea to check both light touch as well as proprioception. You want to assess the patient for tone using the modified Ashworth scale. You can check their reflexes. Definitely want to check for cranial nerve function as well as their functional mobility. So I don't think that there's any surprises here at this point in the semester. You should know that there's 3 different disease stages, and depending on the stage that the person is currently in will depend on what we do with our physical therapy intervention. The disease stage, if it's in the early stage, few minimal impairments, you're going to start with prevention, restorative, and then you might need to add compensatory interventions. So if you're in the middle stage, that person's going to progress, and typically there's a fairly rapid progression. Here you're going to switch with using compensatory interventions, followed by preventative, and if possible, if needed, restorative. And then in the late stage, you're going to notice severe limitations and impairments. In the late stage, you're going to choose compensatory interventions, followed by preventative, and if possible, anything restorative. Please notice that for all of these stages, both early, middle, and late, family, patient, education, and training, psychological support is essential. No matter what stage you're in, this person's going to need that support, education, and training. Things to consider when prescribing exercise for this patient population. And standardly, the exercise prescription is going to be limited to the early stages of the disease. You definitely want to avoid disuse atrophy. Disuse atrophy, when it does happen, if the person isn't doing anything, is going to reduce their function. But again, kind of like Guillain-Barré, you want to avoid that overwork fatigue. And it's going to be really easy to overwork this person with exercise because the muscle is deinnervated and it's more susceptible to overwork because it's already working as hard as it can. You definitely want to monitor for that overwork fatigue. Remember, any kind of decrease in ADL function, any kind of increased soreness, 1 to 3 days after an activity is all indicative of overwork fatigue, and we want to be careful with this patient population when working with them to avoid this. Just like Guillain-Barré, if the manual muscle test for a specific muscle group is less than 3 out of 5, no strengthening against gravity. Okay, another thing to avoid, again, kind of like GBS, is no eccentric exercise, no matter what. That's just going to be way too much work for this patient population. So let's look at the first stage, the early stage. If you look on the right-hand side of the slide, you see the disease stage is early. Evaluations findings should be minimal impairments, no real activity restrictions or participation limitations. So you're going to start mostly with preventative or restorative work and then add compensatory as needed. What you might find early on, especially with limb onset ALS, is going to be mild to moderate weakness. Okay, as I mentioned previously, you have to find that balance between overwork and disuse atrophy. Okay, what's recommended right now is strengthening exercises, only concentric exercises in muscles with greater than 3 out of 5 strength. You're going to choose moderate resistance, approximately 65%, 1 rep max, using 1 to 2 sets of 8 to 12 or 3 sets of 5, and that's it. For aerobic activity, you're going to use 50 to 80% heart rate max 3 times per week, and if the activity lasts for more than 15 minutes, you want to incorporate rest periods during the activity, and by all means, try to avoid fatigue. And then finally, stretching. Active patient stretching or passive range of motion exercises, something that's going to help prevent muscle contractions in the future, is highly recommended. As far as compensatory, in the early stage, you're going to determine the need for an assistive device and any home modification that might be needed. You want to educate the patient and the family on the disease course, and definitely, by all means, similar to GBS, educate on energy conservation techniques. Okay, moving on to the middle stage. Evaluation findings. Now the patient is going to start to have an increasing number of impairments. Some of these are going to be severe, and some of them are going to be mild to moderate weakness. Okay, you're going to start notice a progressive decrease in mobility and ADLs, much more fatigue, and a wheelchair might be needed for long distances, and pain might be present, especially in the shoulders. Okay, why this is true? Because as the upper extremities become more involved, they just hang. Okay, and if they're hanging there, it's going to really put a lot of pressure on the shoulders, and that person might present with some pain. Okay, the other thing that the person might present with is cervical extensor weakness. Okay, so to compensate for these weak muscles, you can use assistive devices or orthoses. So an example of you can use a sling. If you remember, we talked previously when we were working with patients with hypotonia in their upper extremities about using either the Give More or the Bobath slings for the shoulder. That actually gives a lot more support. And to compensate for the weak cervical extensors, a number of different kinds of C-collars for this patient that are available, and yes, just using that C-collar relieves them of having to hold their head up against gravity. This might be the time that you'll have to recommend installing a ramp or moving the bedroom to the first floor, for example, so the patient doesn't have to go up and down steps. You might need to prescribe a wheelchair and educate the caregivers on functional training. And as far as preventative, here you're going to be doing range of motion and stretching, using pressure relieving devices as well as strength and aerobic training as tolerated. But realize if they're really lacking strength, if the strength isn't greater than or equal to 3 out of 5, then you do not want to do any strengthening exercises. Okay, finally, late stage. Okay, late stage, the person's going to be wheelchair dependent or restricted to their bed. They're going to be completely dependent with all ADLs, and they're going to have severe weakness of all their muscles. They may present with dysarthria, dysphagia, they may have respiratory compromise, and pain. Okay, to compensate, you're going to educate caregivers again on the importance of skin care, positioning, turning every couple hours, and for transfers, highly recommend a mechanical lift at this point for safety. Preventative is going to be passive range of motion, pulmonary hygiene, a hospital bed and pressure relieving devices, and skincare. And you want to educate the caregivers on secondary complications such as pressure sores. And the prognostic factors that you should be aware of: a patient has a more positive prognosis if they had a younger age at onset, and that's going to be less than 40 years of age. The limb onset versus bulbar onset. Limb is going to give you a more positive prognosis, but realize already about 80% of patients are going to present with limb onset. There's a longer time between onset and diagnosis. Like I said, there's some axonal reinnervation that can happen due to the denervation after the alpha motor neuron loss. That can happen. So if it's happening more slowly, then that time before diagnosis might be a little bit longer. And also, if the person is less severe at diagnosis, they tend to have a more positive prognosis. Okay, predominant upper motor neuron signs at diagnosis. Remember, that's going to be equivalent to the patient having the PLS. If they're working at a multidisciplinary ALS clinic, if they have a better psychological well-being, the use of that drug, riluzole, that's going to give them an extra 2 to 3 months of life, use of ventilator assistance, big decision. But if they choose to use ventilator assistance, they're going to survive for longer periods of time. And if they have that PLS or PMA diagnosis. The more negative prognosis is going to be having any kind of cognitive abnormality and dementia. And remember, this goes more with the familial presentation of ALS, the one that's inherited. If they have the progressive or the pseudobulbar palsy, they have respiratory symptoms at onset and any kind of malnutrition. That's why it might be important for that person to get a PEG tube before they need it, so that can help with malnutrition. Here's some additional resources. The first is a link to the ALS Association. The second is a really cool video that I'll append to the end of this presentation. It's about some new technology that's coming out to help patients with ALS and other problems still be able to communicate. Even though they've lost function, motor function in the majority of their body, there's some new technology coming out that I thought was really cool.
Up, down, left, right. Everything you are watching happen on this screen right now is being controlled only with Mark's thoughts.
So that just sent out a health notification.
Mm-hmm. He describes it as contracting and then relaxing his brain.
It takes concentration. It's a pretty involved process. It's one I don't take lightly.
This has all been pretty sudden for Mark. He was diagnosed with ALS in 2021. Mark has since lost control of his hands and arms. He will likely lose his voice. Mark didn't hesitate to sign up for a clinical trial to have this placed in his brain. It's called a stentrode.
The one thing about this disease is it affects your physical, but not the mind. To me, it gives me the opportunity to be able to continue to do things that I'm able to do now just by thinking about it.
Was one of the first companies in the world to get FDA approval for human trials. Yay! And Mark is one of those first humans.
That's awesome. Yeah.
It's all the brainchild of this man, Dr. Tom Oxley.
Text messaging is a really critical element of how we communicate with our family and friends now. So that's usually what people mostly want back.
So then that will text the caregiver.
So you just sent a text.
I did.
That's pretty cool.
Pretty simple. Yeah, pretty cool.
Dr. Oxley is a neurologist who first started thinking about the possibility of brain implants while in his native Australia.
For people who have got paralysis or motor impairment, but they have that part of the brain still working, then if you can put a device in, get the information, get it out of the brain, then you can turn what previously was a signal controlling your body into a signal that controls a digital device.
The Stentrode is the device that Oxley and his team at Synchron created. It's a cage of thin wired mesh with electrode sensors that can detect electrical brain activity, translate that activity, and then transmit it to devices such as a phone or a computer.
It's amazing. That's all I can say.
And just like a stent, it doesn't require open brain surgery. Instead, it's able to travel through the body's natural network of veins and sit in a major vein right in the middle of the brain. The procedure is minimally invasive, and you can't see the device just by looking. The Stentrode is threaded up through a vessel along the neck.
Right here you can feel a little cable. That's actually connecting that stent to a device that now sits right underneath the skin here. And it's from there that the signals are sent out that can help him control these devices in his environment.
Our brains have billions of neurons firing electrical impulses that control our movements, everything from shaking hands to taking a step. Each and every one of those actions is associated with a specific electrical signature. The Stentrode, which again sits right here around that area of the brain responsible for movement, learns to recognize those specific electrical patterns and essentially creates your own personalized dictionary of movement.